Hi everyone, welcome back to UCLA Health's Medically Speaking. I'm your host, Dr. Eve Glazier. Today we're exploring an area of medicine where timing truly means everything, when every minute can make a tremendous difference in a patient's future. We're talking strokes. Strokes can transform life in an instant, and not just for the person experiencing it, but for their family and friends too. And they're so frightening that most of us file the thought of them under "that'll never happen to me." But here's the thing, they do happen. 1 out of every 4 people will suffer a stroke in their lifetime. And so when I look around our studio, there's 4 of us in here right now, statistically means that at least one of us, are going to have a stroke in the course of our lifetime. The good news is that there's so much we can do. We can lower our risk factors, we can recognize warning signs, and we can get life-saving treatment quickly. And there are remarkable clinicians leading this charge, and joining me today is one of them, Dr. Nour, UCLA Health interventional neurologist and founder of California's first mobile stroke treatment unit. Welcome to the podcast, May.
Thank you so much. It's such a pleasure to be here.
I'm so glad you're here. May, can we just start at the beginning? When did what first sparked your interest in neurology, and then more specifically in stroke medicine?
That's a great question. So I think we're most influenced by mentors. So I did a PhD in neuroscience before going to medical school.
Wow.
And my work was in gene therapy for inherited retinal degenerations. But my first experience in clinical medicine was on a rotation with a neurologist who was just absolutely wonderful. He was terrific with the students and teaching. He was terrific with his bedside manner of the patients. He was terrific in explaining to us. And I said, wow, this is a field I really would love. Maybe I could do this. My dad is a transplant surgeon. So my first sub-I did, I have to do transplant. And I love transplant, but not for me. So as soon as I did the stroke rotation and neurology rotation, I said, wow, I find myself here. I find myself relating to the patients. I find myself making an impact. And furthermore, specifically for the interventional, I was doing a sub-I at Mayo Clinic, and one of the physicians was telling all the residents and all the fellows, if I were to go back, I would be an interventionalist. I would take the patient from the ER to the angio suite to following up, and how wonderful would that be? And I said, nobody's telling me about this. This is what I want to do.
I wonder why they weren't telling you about it.
Because I was a medical student. The medical student in the corner. But that's okay. That
Right.
makes me much more sensitive
Yes.
when we're teaching our students to include them,
Right.
to make sure we answer their questions, to make sure that they're part of the conversation, to make sure that they feel that they're the future.
Oh, I love that.
But that was the moment, honest to God, that was a life-changing moment for me. As a fourth-year medical student, I said, I'm going to be an interventional neurologist. And so...
So going back to, just to add on to what interventional neurology means. So I think you talked about using techniques then, though, to kind of remove clots or stopping bleeding.
Yes,
That's kind of the difference between being a traditional neurologist and an interventional.
Well, it's a minimally invasive surgical practice. And just like somebody would go to the cath lab and get a stent for their heart, we could put stents for blood vessels of the neck or the brain. We could stop bleeding in severe nosebleeds, or in patients who have head and neck cancer, help them with bleeding complications of the cancer. We, of course, for stroke, can go there and immediately remove the clot and return blood flow to the tissue of the brain. Because as you know, and as you mentioned, minutes matter.
Yes.
And every minute that there's lack of blood flow to the tissue of the brain, 2 million brain cells die.
Yes.
So acute action, fast action is so critical and so important.
I love, though, hearing that what got you into it, too, just to go back, because even when you talk, you exude so much compassion and connection. So I love, though, that you're thinking about this ophthalmology, but then this person who clearly, demonstrated kind of compassion, and I'm guessing a lot of just diagnostics, probably that thoughtfulness extended to diagnosis, was that real inspiration for you?
Absolutely.
Right.
And
then fast action.
And then life is sometimes a series of happenstance.
Yes.
And I think that person, that mentor, those mentors were put in my way, in my path, so I can have the career I have today, and I'm so grateful to them.
Oh, I love it. Well, at the end, I want to ask you about who you're mentoring, because I have a feeling that you mentor in turn. Let's just start with some basics, just for our audience. I mean, what is a stroke? What defines a stroke?
Great question. So stroke is when there is either lack of blood flow to the tissue of the brain, and so the tissue of the brain doesn't survive and dies, or there is bleeding into the tissue of the brain. The majority of strokes that we will see and that people will experience are actually lack of blood flow type strokes. So they can be a blockage in a tiny blood vessel or a large blood vessel. So about 80% of strokes are ischemic in nature, where there's lack of blood flow, and about 20% where there is bleeding into the tissue because of many reasons. Could be high blood pressure, could be a problem with connections with the vessels, could be a ballooning of the vessel like an aneurysm. And both are devastating, and both are devastating in different ways. And I like to give for our audience, the understanding that the brain is like real estate. It's all about location, location, location. So let's say you have bleeding into a tissue of the brain that affects strength, then somebody will lose strength. Let's say lack of blood flow. Let's say a tumor that's sitting there. Let's say a seizure that happens there that incapacitates those neurons or brain cells. You will still have the same outcome. Somebody's arm is weak.
Right.
Or we've heard of patients having migraines and they look like a stroke, but they're not. So there are stroke mimics that present looking like a stroke. And that's why in stroke, not only do minutes matter, but do immediate diagnosis is very important, because not everything that looks like a stroke could be a real stroke.
Right. So it actually takes some nuance. What actually happens in the brain when a stroke happens? So whether it's caused by, I think you mentioned ischemia, which is kind of death, or something like blood flow isn't getting to tissue, or hemorrhagic, which is there is bleeding, too much bleeding into the tissue. But what's happening inside the brain then? The
brain, whatever function that area is responsible for, is incapacitated, basically.
Like it dies, or it's incapacitated, or
dies.
Both? Yeah,
it dies. And the brain is not like, other organs which may regenerate. The brain is, once these cells are dead, nothing makes up for them. But with time, with rehabilitations, other cells can take over that function and help the patients to recover. But those cells, once they die, don't regenerate again.
That's really, that's overwhelming, honestly, to think about. But just to reiterate what you said, the outcome is really depending on what region of the brain is affected.
100%.
Okay. And I mean, when you say brain cells die, like a lot of brain cells die?
The brain is also about eloquence of the tissue. So sometimes a big amount of tissue, and you can see a patient with very minor deficits, and sometimes a very small amount of that real estate or that tissue, and the patient is devastated clinically.
Yeah. It's so, and it can be so life-changing. So we started talking about just how precious the minutes are. And I guess my first question would be, if the damage is starting, let's say in one region of the brain, can it spread or worsen over time, or does it depend on maybe what kind of type of stroke it is?
Typically, the damage is contained. Typically, whatever's, the area that's subserved by that blood flow or whatnot, typically it's contained.
Okay. And so, talking about everything that you can do about it, which is exciting and promising. So what are some of the treatments that an interventional neurologist like you do if a patient's having a stroke?
I think even to take one step back,
please.
What are the symptoms of a stroke?
Oh, yes,
so our audience can recognize,
yes, for sure,
right?
Sure.
So because we want the interventionalists to be involved swiftly,
very swiftly,
we have to take the responsibility of recognizing in ourselves and our loved ones. The thing about stroke, it's not like a heart attack. It's not painful. Patients don't say, oh, my chest hurts or this hurts or that hurts. So the thing about stroke is that it's painless. And sometimes the patients don't recognize the symptoms as a result of the stroke. We have this concept called neglect. Patient doesn't understand that that's side of their body that's weak. So the most critical thing is that we recognize, and we can recognize and by giving the audience an acronym to remember.
I love acronyms.
And the acronym is called BEFAST. Okay.
Perfect.
B stands for sudden changes in balance. E, sudden changes of eyes or vision. So somebody can lose half of their vision or their whole vision, or see double. That happens suddenly. The hallmark about stroke is it happens suddenly. It's not something that creeps up over weeks or months. Sudden change in outcome. F stands for weakness in the face. So somebody can have a facial droop. A stands for weakness in the arm or leg. S stands for changes in speech or language. So somebody is not intelligible in their speech, they're slurred, or they can't quite understand what you're telling them, or you can't quite understand the words they're making out. And T is time to call 911. Again, to come back and emphasize every single minute matters.
Right, and be fast.
Be fast. So now what does the interventionalist do about that?
So what I've noticed sometimes is that people think that the symptoms of a stroke are going to be very dramatic, like just like when you're watching a movie and someone has this like very like prototypical heart attack. But not only our symptoms can be subtle, and so we're asking, families and, partners and kids themselves to be aware of subtle changes. But what if you're by yourself? Like, what if I'm by myself and I look in the mirror and I'm like, oh my God, like, is my face drooping a little bit? Like, what should I do?
Yeah, the biggest problem is that sometimes stroke is not, the awareness of stroke is not there for the patient. So the patient can be weak on the left side of their body, and actually part of the stroke syndrome is that they don't recognize that this is their limb. So how do you deal with that?
Right.
I think we still have a lot to do in terms of innovations that actually automatically detect stroke symptoms.
You mean like a wearable?
Like a wearable, like so many. I mean, we have something very simple now, something called the Apple Watch. We have it already.
Maybe you've heard of it,
right? Where somebody can fall and it can call 911.
Absolutely.
What about an idea, or if somebody's blood pressure surges and they fall, and this, an algorithm? We have so much AI advancement.
So much.
We have to put our forces towards detection of stroke that patients do not recognize. What about stroke during sleep?
I was just going to say, can you detect oxygenation in the brain?
Yes, a lot of atrial fibrillation patients actually have stroke in the early hours of the morning.
Right.
So there's sleep.
And so all these minutes have gone by.
All these minutes, and then somebody discovers grandma the next morning. Why is she not waking up for breakfast? Oh, she had a stroke. So what if there's a wearable that sleeves off of a watch or any other device and sees, well, the rhythmic movement of grandma is not the same tonight as it was every night.
Right.
That calls an alert. So I think we have to put so much effort into innovating devices that will detect stroke that patients don't recognize, and for patients who are alone and don't have someone to recognize the symptoms.
I can't wait to do this startup with you.
Let's do it.
I know.
Let's do it. I pitched it to Apple.
Yeah.
But they were like, okay, bye.
Apple, are you there?
Yeah, exactly.
Okay, no, that's very, very helpful. And I guess I would say is that if you do have the whereabouts to understand that something is going wrong, call 911.
Absolutely.
Is that right?
Absolutely.
Right. So don't even call your friend first.
Nope.
Call 911.
Don't call a friend. Don't call a daughter. Don't call a son. Don't call your spouse's phone. Call 911.
Yes, I have to say, like, as providers, we like to be bothered. I know that seems counterintuitive, but we like to be bothered. The worst thing that happens is what? You go to the ER and you don't have a stroke?
Exactly.
Fantastic. You think that anything's wrong, please call 911.
Yes.
Be fast.
Be fast.
Can I go back before we do the treatment really fast? So,
Yeah.
I mean, I love that it's first of all, it's like a very memorable acronym. So anyone can learn it. Definitely teach, their family. I hear that you're saying that they happen suddenly.
Yes.
I do think that sometimes, like, when I think about, like, the cinematic version of, like, a heart attack, it's always like, it's like, but with, like, strokes, I mean, I understand these happen suddenly, but can they be subtle? Can the signs be subtle?
Yeah, the signs can be subtle. And when the general public thinks of stroke, or when you say the word stroke, what does that mean to you?
Someone, like,
somebody's
collapsing,
completely paralyzed.
They're like really like slurring their speech.
Exactly. They can absolutely be subtle. So even subtle changes in our loved ones, we should be very cautious about. And the most critical thing is not, to discuss it or call a family member. It's to call 911.
Yes.
It's to call 911 for many reasons. One, because time is everything.
Yes.
Two, because the paramedics will take the patient to the center of stroke care that is most reliable for their condition based on the severity of symptoms. Three, because people can change fast. People can deteriorate fast. God forbid we take our loved one in the car and something bad happens and we cannot handle that.
Right, you can't help because you're driving. So and also because timing is everything. I just think this is an important point. I've just, in my own experience, I've had patients who've had strokes or their family members, and they're like, something was a little bit off, but I didn't know. And so I just really want to encourage, our community and our patients, if something just seems a little bit off, and that's why it's so important to know a baseline, right?
Absolutely.
Something seems off, call 911.
Absolutely.
So I think that's a really important point. Call 911 there.
Call 911.
Okay.
Absolutely.
So yes, now tell me the amazing things that you do as the interventionalist.
So as a vascular neurologist, the patient comes immediately to the hospital and we assess them.
Okay.
And the treatments, first, the most critical thing is to get imaging. Do we think this is an ischemic stroke where there's a lack of blood flow, or there's a hemorrhagic stroke?
Right.
The medications that we have for each of these are vastly different, right?
Right.
So let's say there's an ischemic stroke, the most common kind of stroke. We have clot-busting medications. But the other importance of time, we come back to this fact that medication can be only given 4.5 hours from the last time the patient was seen their normal selves. I always like to ask the family members this way, not when did you last see grandfather normal?
Yeah.
When did you last see him his normal selves?
Right.
Because patients
normal
have
self
different
is very
deficits,
relative, right?
Right?
Yeah.
And not when they went to sleep the night before, and when did you see them well? And sometimes that's, before they went to sleep. The fact that they got out of bed and fell this morning doesn't mean that their last known well time was in the morning. No, it was the last time they were seen normal.
Okay.
Why is that critical? Because we can give life-saving medications or brain-saving medications like clot-busting medications, but only within 4.5 hours. Within 4.5 hours, they may help. Out of 100 patients who take these, 30 will do better. 3 may do worse. God forbid one may die because of hemorrhage. But you could do that within 4.5 hours. So when you give them outside of that time window, the risk of hemorrhage or risk of bleeding as a result of the medication increases. So we don't give the medication during that time.
Okay.
So now that's the medical management of stroke.
Right.
And let's
Do you always start with that if you
Yes,
can? So if you
yes.
can, you start with the medical intervention.
Always.
Okay.
Always with the medical intervention.
Okay.
That's for ischemic stroke. Let's say
Right.
somebody comes with a hemorrhage. There's a brain bleed, and they're on a blood thinner. We can immediately reverse that blood thinner.
The effect of that blood thinner, right?
Exactly.
Yes. Okay.
We can decrease the blood pressure, so we decrease the rate of expansion or
Right.
blooming of this blood. And we can get them on seizure medications because that's something that commonly happens when we have something irritating the brain like blood. So now we are done with the immediate emergent medical intervention. What about the endovascular or interventional services? So let's say a person has a blood vessel that's blocked. It's really about opening that blood vessel on time before the tissue dies, not opening in general later.
Right. Don't do anything.
So we give the clot busting medication, but the clot busting medication does very well for tiny clots, but for big organized clots, maybe 20 or 30% of the time it can dissolve that clot, and not always on time. So in spite of giving that medication, we immediately proceed to the angiography suite, which is kind of like a small operative room, except we use X-ray beams to understand what's happening in the brain and visualize the blood vessel.
Right. So that's what the angiography is.
That's the
Right.
angiography. So we are injecting the blood vessels with contrast. We can see that as a tree or a map, and in a minimally invasive way, either go in through a blood vessel in the wrist or in the leg or even in the neck or in the arm sometimes. We go all the way up and
You
thread,
just, like, thread your way.
catheters. Catheters
It's
are
just
tubes.
amazing. Yes.
Go all the way up to the tissue of the brain, inside the blood vessels, and mechanically remove the clot. And believe it or not,
Like just grab it and then
grab
pull it out.
We can aspirate it. We can suction it with a machine, with a little pump, with tubing. Or the first stent retriever was actually invented here at UCLA. And what is that? It's like a stent is like a mesh, like a chicken wire, and it's hollow like a tube of pasta, but it's on a wire.
Yeah.
And then you implant that inside of the clot, and you allow it to grab the clot, and then you pull that out. And immediately when you pull that out, you see the patient miraculously improve on the table.
That's amazing. As soon as that blood then
So,
reaches, like the tissue, the word is perfuse, right?
Exactly,
But then all of a sudden those cells, right?
Yes.
Get all the nutrients, the blood, and then start
Yes.
functioning again.
And the grandfather who was paralyzed, who was unable to talk to their family, can now lift their arm, can lift their leg, can integrate into life again, and can be have a meaningful life. It's not, we never extend life,
Yeah.
but we help to improve quality of life.
It's incredible and really moving. And all time. It's all about time.
All about time. And another important thing for the audience,
Yes.
age doesn't matter.
Oh, good.
The oldest patients I've personally helped to return blood flow, it was 101. Age doesn't matter. It's all about quality of life.
Right. Well, and then also, I mean, I just want to, this is why, like, though, paying attention to
Yes.
how you are normally, paying attention to if something changes, right? And listening to that gut feeling. I'm not sure you're having a stroke, but something feels a little off. Call 911.
Yes. Much better to be checked than miss something.
I agree. I think that's just such an important message. I think sometimes people get really deterred. They're like, oh, it's just a subtle symptom, or it's something else is going on, or I don't want to go to the emergency room.
Yeah.
It makes a humongous
Yes.
difference in your outcome.
Yes. In fact, I'll tell you a story about
Please.
a patient I saw today. And the patient is a physician and his wife is a physician. And he had a stroke in the past, and he had some subtle symptoms. And his wife felt that maybe they're being overbearing. Like, I don't want to disrupt people every time and call, well, his speech is a little slurred. Well, in fact, turned out that was a stroke from 3 weeks ago.
Oh, wow.
So sometimes we feel that we may be inconveniencing. We're not.
Yeah.
We're not. Brain is precious. Call 911.
Yes. Yeah, and you're precious.
Yeah.
Oh my God. Okay, let's talk prevention,
Yes.
right? Because I think that's really important. So, I mean, first of all, great. We've talked about, signs, symptoms, getting yourself to the emergency room, different ways that we can break up a clot, right? Or remove it, or reduce and stop bleeding. And again, I think that people are like, oh my gosh, 1 in 4 people have strokes, or oh my God, they're so debilitating and catastrophic. But I really want to emphasize that there's something called prevention, right? And so we absolutely can affect that, and we all need these actionable takeaways. Tell us, what are the major risk factors for having a stroke?
Absolutely. And I can even start by telling you something very important. 80% of stroke is preventable.
That's
Believe it or
incredible.
not. 80%. That's great.
It's great.
We have so much we can work on.
Yeah.
Let's talk about things we cannot control. Things we cannot control are our genes. If we have propensity to have high blood pressure, propensity to have high cholesterol, etc., we cannot change our genes, but we can change our environment and how we act about things.
But even that, you can change your risk, though.
Exactly.
Even with the genetic risk.
So the risks are the common things that you can think about: diabetes that's not well controlled, high blood pressure that's not well controlled, smoking, illicit drugs that pump up the heart, like cocaine or amphetamine, irregular heart rhythm, like something called atrial fibrillation, that disease of the vessels because of high cholesterol that's accumulating, et cetera, et cetera. There's so many risk factors. There are other risk factors when we talk about genetic, that somebody's born with a disorder that makes the blood more thickened at some times. There are many, many risks, but even trauma can be a risk. Even a healthy child can have a stroke. People tend to think of stroke, oh, it should happen to somebody older.
Yes.
Stroke can happen at any age. Stroke can happen at any age. The smallest example of that, we had a child who jumping on the trampoline and hurt their neck. Maybe didn't even feel it hurt their neck. A day later had a stroke, because our blood vessels are like an onion with multiple skins. And when we have mechanical shearing of that, by small things, we've had patients this is called dissection, who've had experienced these dissections, even reclining back at the hairdressers for hair washing, or going on a roller coaster, or having a big fit of coughing for 3 weeks or whatever, and they may damage the blood vessel. And what happens is that small blood clots will get caught between these layers, and then they travel all the way up to the blood vessels of the brain and block them, and then you have ischemic stroke that way. So one important thing is that stroke can happen at any age. There are risk factors we know about, we can control. And we should all try to reduce our risk. Nothing eliminates risk when you have risk factors, but we can definitely reduce risk.
Oh my gosh, there's so much. And even if you're born with that, propensity to, your blood is thicker and you might clot more than the next person. When we know that, though, we can give things to thin your blood.
And another very, 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 very crucial thing I didn't mention, healthy diet and exercise.
Yes. Tell me what that means for you.
For stroke risk prevention, a Mediterranean diet has been shown to help reduce risk of stroke. What does that mean? Healthy fats like avocado, olive oil, nuts like almonds, pecans, and so forth.
Great.
Lean meats, less red meats, and more proteins that have white meats, beans, and so forth. A good variety of fruits and vegetables. And, maybe a few years ago, there was this thing, if you have a glass of wine a day, it prevents you against stroke or heart disease. But I really think it's the flavonoids in that red color.
Yes.
So if we think about very healthy fruits and vegetables, things that have that red color.
Yes.
Beets, berries, grapes, and so forth. Those can be preventative against inflammation in the body as well. And then exercise. Exercise is important. You have to do exercise that helps you as we age with balance, something like yoga and Pilates and stretching and things that build up our muscle mass, but also cardiovascular exercise. 3 to 4 times a week, good 20 minutes to just pump up our heart, even if it's a brisk walk. We can all do that.
Yeah, we can. I think that this is what's counteracting, I think, what sounds very scary for people. But for us to focus on, these are all the things that you can do or not do in some cases. Please don't do, these, really, some of these illicit drugs are so bad for you and your heart. And even some of these conditions you might just accrue as you get older or run in your family, diabetes, high blood pressure, those can all be modified, and the risk can be so greatly reduced. I think that's incredibly
empowering.
Encouraging and empowering. Absolutely. And you have agency and autonomy. Like, life doesn't have to just happen to you. You can happen to your own life. So what's amazing to me is that in addition to just being the expert that you are, you've built something, and I want to talk about that. You've innovated. So to me, like, what I see is that you've probably been in the field all these years, maybe even starting in your 4th year when you first explored neurology. And clearly you saw, how precious these minutes were. And it sounded like you decided to not just flip the model, but create a new model and really innovate and bring the hospital and those features of the hospital that are so critical to this process of mitigating, the damage of too much time going by, meaning like imaging, right? Because it seems like the big process is getting imaged, and then getting a clot busting drug or stopping bleeding. And so tell us about the mobile stroke unit.
Absolutely. So as you said, I was inspired by the many patients I've seen, but not just the patients, the families. There's a lot of caregiver fatigue that's involved. There's a lot of unanswered questions. Patients suffer through so much. And when I saw that, I really got inspired. And I said, I want to do something that can revolutionize, that can change things in our county, that can create something different. We have to be visionaries. We can't think about, what can be under our feet today.
Yeah.
We have to think about in 10 years, how can we create change? And so the Arlene and Henry Gluck Mobile Stroke Rescue Program that UCLA Health has just so much supported is a county initiative. It's not just the UCLA Health initiative.
Yeah, in LA County.
LA County. And LA County Emergency Medical Services has designated us as a shared regional resource of EMS. What does that mean? Unlike any ambulance that when you call 911 will come, or fire engine or so forth, this is a primary stroke center on wheels, or a hospital on wheels. We bring the hospital to the patient because we know time matters. And so the ambulance is equipped with actual CT scanner where we can see the tissue of the brain and also the blood vessels of the brain. We can tell if the blood vessel is blocked.
Like right away.
Right away.
Like you pull up somewhere and like within 5 minutes?
Within 5 minutes.
That's how long it takes?
The scan takes 30 seconds. This is within how many?
That's incredible.
Yes, exactly.
Yeah.
But the key is that we are actually dispatched with the 911 services. So Santa Monica Fire Department, Long Beach Fire, Beverly Hills Fire, LA City, LA County, Culver City Fire. We are live with 8 different fire departments in different regions of the county where we are there with the primary crews, with the firefighters, with the engines, with the ambulances. We determine if the patient is having likely a stroke. And if they are likely having a stroke, then we'll admit them to our ambulance. And our team, it's very exciting to be there because you can really impact change. You can
right
there. And without transporting yet to the hospital, without taking all that time to register, without taking the time to get wheeled to the imaging, without waiting for the pharmacist to mix the medication.
It took us 20 minutes just to say that.
Exactly. So basically on the ambulance is a firefighter paramedic, and we have partnerships with different fire departments. For example, Torrance Fire, Long Beach Fire, Culver City Fire, who staff us. A physician, either in person or by telemedicine, because you want to expand the reach of that physician to everywhere. Now we have 3 ambulances, so now I can cover 1, 2, 3, and in fact covering today. So
you can literally sit at this table and you can consult from here as all 3 go on emergencies.
Exactly. In fact, the last time I consulted on a mobile stroke unit patient, I was in the middle of removing clot from another patient's brain, and
like in the OR.
And then we had a telemedicine projection. Okay, 1 patient we're working on here, 1 patient on telemedicine. That patient turned out to have a blood clot as well. And that patient ended up coming to our hospital by virtue of where they were in the vicinity. And I scrubbed out of this case and finished it and went to the mobile stroke patient, removed the clot from her brain, and she was completely normal after. How gratifying. So technology has changed a lot.
I don't know why I would ever need to see like a Marvel movie. I could just watch you all day. I mean, are you kidding?
It's really amazing.
So when the ambulances are out there in the field, and you're, let's say, like consulting from this table, if they see a clot, will they wait for you to remove the clot, or will they do any other intervention in the mobile stroke unit?
So we actually have the same medications that are in the hospital on the ambulance.
So they can get the medication
clot busting medication. We can reverse
and
bleeding,
lower blood pressure.
We can lower blood pressure. We can all of these, and most importantly, know what the diagnosis is, so we can route the patient to the right hospital from the beginning.
That's right. And when you say right hospital, why do you have to say right hospital? Does not every hospital have?
Exactly.
Okay.
So every hospital has different level of stroke privileging or certifications, or the things that they have the ability to offer. Some are not stroke centers at all. Some are stroke centers that can give the medications through the IV, like the clot busting. Some have interventionalists there 24/7.
Like you,
And some have neurosurgeons there 24/7 to deal with hemorrhages. So you have to take the patient to the right hospital. That can cost them their life if they go to the wrong one, right? So now we have conclusive diagnosis in the field. We're able to take the patient to where they need to be. And the most important thing is that although we're operated by UCLA Health, we are a shared regional resource of the county. What does that mean? We are a community resource.
Yeah.
We drop off patients at over 24 hospitals within our county. And this is in an effort to improve stroke care everywhere.
Right. All over Los Angeles.
All over Los Angeles.
Right. I mean, it's such an amazing demonstration of health equity in that way. Very making sure that everyone has access to life-saving care, right?
Yes.
No matter where they are in the county.
Yes.
That's so incredible. I still can't get over that you can just do like the brain imaging, in the mobile van. But also, I mean, thank you for explaining too, because I don't know if everyone also understands, like I didn't, that there's different stroke centers and level of care. And it really is, again, that's another part of getting there on time. Just amazing. Tell me about the program. I mean, has it been successful?
It has been absolutely wonderful.
I want to hear all about it.
What a journey. We started our first clinical operations in September of 2017.
Mm-hmm. I actually remember this, yeah.
Yeah, 8 years later.
Yeah, it's fantastic.
Still going strong.
Yeah.
And all of that by support from philanthropic funds and special project funds and support from LA County Board of Supervisors. We have been just so fortunate because every day we can operate, we can help more patients.
Yeah.
And in fact, part of our study for the county is that we did geospatial mapping for the incidence of stroke all around our county. So the patients who had final hospital diagnosis of stroke in the hospital, we went back and looked at the longitude and latitude of where they were picked up from by the 911 EMS services. And we found where the stroke hotspots are because we want to direct these resources to the areas where they need it most.
So did that also then inform like stroke prevention?
Absolutely.
Right. So if you're like, here's a hot spot, does that mean like,
Yes.
oh, we need to put more primary care in for
Yes.
prevention
Yes.
and diabetes care?
But you found a very interesting pattern, that's something we already learn about from the textbooks, right? Our genes play a lot into it. So we found major hotspots in San Fernando Valley, where primarily Hispanic population, San Gabriel Valley, primarily Asian population, Inglewood, primarily Black American population. So we know genes play a lot into it, but also access to preventative services, access to health care.
Right.
We have to do better. We have to do better by our patients.
Yeah, I mean, the access is, I just think, is such a huge part of it. I mean, because to me, you've built something that goes way beyond technology, right? Because it is about access. I mean, just because, something, bringing a hospital to you, yes. I mean, that's access. And it sounds like, though, you see a lot of inequities in not just stroke care, but in stroke prevention.
Absolutely.
So what do you think the best ways are to address that? I mean, it sounds like having mobile units that can be deployed, but anything else?
I think education plays a lot into it too, about the importance. How are these factors, how are these 20 years of uncontrolled blood pressure really affecting me? People don't understand that until the day the stroke happens.
Absolutely.
Our job is to educate also. Yeah. In the downtime of the mobile stroke unit, we have the unit everywhere. We have them at health fairs, and we have them stopping at the street talking to patients who just read the name or are curious, what is this thing?
Yeah.
And then this is an opportunity for us to educate about early prevention, early notification, diagnosis, treatment, how we can help our patients.
Right, and if not for you, for your family.
Yes. Yes.
Right, and then we've got this great acronym that anyone can remember.
And I encourage our listeners, our viewers,
please,
to teach that to 5 of their family members.
Yeah.
BEFAST. Learn it for yourself and teach it to 5 people you love.
I think it's such an important reminder. I have to say, I think that it still feels like that people assume strokes happen to older people. Yep. And I can think on my right hand, 5 of them in their 40s who have had strokes, and you're going to tell me that kids have had strokes, especially when there's, a mechanical or, disruption, but that's incredibly important to remember. And often, though, it's a family member who says something isn't right.
Yes.
And so I just want to really keep hammering that message of, like, listen to yourself.
Yes.
Don't stay home.
Absolutely.
Oh, that's incredible. What are your other kind of plans for the mobile stroke unit? What are your, what else do you think we can do for stroke prevention and just...
We have to
prevention.
Dream big, continuing to expand services with a fleet of mobile stroke units that cover the entirety of the county.
A fleet,
My dream is for us to be the leaders. Los Angeles County should be the leaders nationally and in the world to say, this matters. We should really incorporate this into become part and parcel of EMS care. Every patient should have access to this. Not only the patients who are lucky when we're operating 7 to 7 in San Fernando Valley or Long Beach or whatnot.
Do these mobile stroke units exist anywhere else in the United States?
They do. Actually, they started in 2014 in Texas, but they originally started in Germany. Because in Germany, they have physicians riding ambulances for advanced life support calls anyways. And they said, well, okay, we treat heart attacks this way. How can we treat stroke? Well, we need a scanner. First we need to diagnose. So actually the engineer who built this brilliant guy, he was motivated by the fact that his brother had a ski accident and he was in a remote area where no brain imaging was available. Yeah. And he passed away because of a big brain hemorrhage. He dedicated his life to make a compact scanner that could fit in an ambulance. That's how it all started. They put these on in Berlin and other areas in Germany, and they said, oh wow, okay, now we can affect care.
Yeah.
We call these golden hour emergencies, where the first 60 minutes really matters into the outcome of patients. And so we were part of a big clinical trial called BEST MSU. We do everything in medicine by evidence-based, of course.
Yes.
And so anecdotally, as physicians, we know if you treat a patient sooner, they will do better.
Yes.
But we needed to prove that if you treat them sooner on an ambulance, they will do better. So as part of the Best MSU, there were 7 mobile stroke unit programs in the nationally that participated, including our Los Angeles County UCLA Health Unit. And 1 week we looked at patients' outcomes when we give them clot-busting medications in the ambulance. And the following week, the patients were randomized to just receive normal care, get to the hospital, receive the same clot-busting medication. And we asked the question, how did these patients fare? They got this faster versus if they got this same medication later. Out of 100 patients who got treated earlier on a mobile stroke unit with the same medication rather than later in the emergency department, 27 had a less final disabled outcome, including 11 of whom were completely disability-free. Wouldn't we want this for our loved ones?
We should demand it.
We should demand it.
Yeah.
Exactly.
This is amazing.
Yeah.
Oh my gosh. Okay. Is there anything I didn't ask you though about stroke prevention, risk factors that I forgot to ask you about?
Maybe we can talk about aneurysms because
I would love to. Oh, yeah, that was my next question. Yes,
Yeah.
is that those are definitely like out there.
Yes.
And I think whether celebrities have been diagnosed them with or not, but I think the question is that what is an aneurysm, and then is it a risk factor for having a stroke?
Yeah. So great question. What is an aneurysm? An aneurysm is a ballooning or an outpouching of a normal blood vessel. As you imagine, if you have a balloon and you inflate, what happens to the latex of that? It gets thinner and thinner and thinner. So the bigger the aneurysm is, the more likely it is that it can rupture. We also know that there are some risk factors that control who's likely to have an aneurysm and what is the likely risk of its rupture. But to even take a step back, how prevalent is this? We said in stroke 1 in 4, right?
Yes.
So to give a frame of reference, in the U.S., about 1 in 50 of us are walking around with an aneurysm.
Right.
They don't give symptoms until they, God forbid, rupture.
Right. And again, the aneurysm, it's a thinning or a bulging. It's nothing's exploding in your brain.
Nothing is exploding in the brain until they rupture. Until they rupture. Right. So it's a thinning. So if you think of it, how can we say it in kind of like an anecdote to it is like a tire.
Yes.
It has a little blowout. It doesn't explode, but there's a little bump. And that bump is a weakened part of the tire. The same thing for the blood vessels. Now, what are the risk factors of developing an aneurysm? Again, family history is a risk. If you have 2 or more first-degree family members, you have a slightly increased risk to have aneurysms. That's one risk. Smoking, tobacco. We know tobacco is not good for our vessels for stroke, for heart disease.
Any blood vessels, yeah.
Even for the aneurysm, it weakens the vessel wall. Again, the drugs that pump up the heart, cocaine, methamphetamine, others. Other things, increased use of alcohol, that's, alcohol abuse. These are the most common things that we think about in terms of aneurysm risk, but also, again, our genes. Who are 2 of the populations that are highest risk, even when we do an aneurysm risk scoring of how likely this is to rupture over time? Japanese and Finnish. 2 genetic populations who are at a higher risk when you have the aneurysms develop for them to be more dangerous or for them to rupture and so forth.
Do we know why?
We don't know the genes. This is so... we are all born with different tensile strengths to our vessels. And that same wear and tear, my same 10 years of high blood pressure, and someone can cause an aneurysm and someone can cause nothing.
Right.
So I think a lot has to do with that.
I think someone's listening would probably say, how do I make sure I don't have an aneurysm?
Yes. So I think the big message is that we don't need to panic. Not everybody needs to have a general screen for aneurysms, but if you have 2 or more first-degree family members with an aneurysm, I recommend to screen.
Yes.
That whole generation.
Right, and you screen really with important. A CAT scan or MRI?
You screen with anything that ends in an A. So A stands for angiogram, so you want a CT angiogram or an MR angiogram. Both of them will show you the blood vessels of the brain and if there's bulging.
Right.
If aneurysms and when aneurysms are discovered early on, God forbid, before they rupture, we can treat them.
Yes.
No, we don't have to have a big brain surgery. Sometimes we need to, but most of the time we can do a minimally invasive. Again, interventionalists such as myself can go in through the blood vessels with leg, arm, etc. Go all the way up to the blood vessels of the brain and put tiny coils. And that's another invention that happened at UCLA.
We're so great.
The first, exactly.
I was going to say.
The first treatment for aneurysms where you put these tiny, tiny platinum coils. What is the purpose of the coils? Because it's metal, it causes the blood to clot. So if you deposit them very carefully inside of this very fine aneurysm, then it will clot off and no more blood will go in there to keep it expanding. And sometimes we have to do that in addition to using a stent or whatnot, depending on the shape of the aneurysm.
Yes.
And in some cases, patients need surgery for clipping or mechanical tying off of the neck of the aneurysm. But in so many cases now, we're doing everything endovascularly, whether the aneurysm comes ruptured,
yes,
or we know about it and we can treat it.
Endovascularly meaning through the vessels.
Through the vessels.
Right.
And so patient,
you don't have to cut open.
Yeah, no. Patient wakes up, they think they're going to have major surgery. They don't have a major surgery.
Yeah.
They're walking, the next few hours.
It's incredible. I mean, what do you think? I mean, like when you first started becoming interested in stroke medicine, how do you feel like the field has changed even since you were first interested?
It's amazing. It's amazing. Even the procedure called mechanical thrombectomy, or removal of the clot, when I started as a resident and I was applying for interventional fellowship, in fact, many people were, field of intervention is going to die. The stroke trials don't show that if patients, you remove the clot, they do better, etc. There were just 1 or 2 trials that were not very well designed. And then all of a sudden, monumental change. 2014, 7 positive trials showed that if you remove that clot, that patient will do so much better. And all of a sudden, the field completely flourished. What I love about that field, interventional field, is that there are so many innovations in technology. A new stent, a new this, a new that, and all of that for the betterment of the patient.
Yes.
And it changes so fast, you can barely keep up. This is a new device, this is a new device. So you have to be comfortable with what you have on the market that you can use, that you're comfortable with, that you know is reliable, but also you have to be open-minded because many new generations of these devices evolve every day, and
so
we
much
have
innovation.
to use them for the better of the patient.
Something you mentioned, what was really poignant was just, obviously the person who's undergoing the stroke and, probably in my goodness, hopefully if they survive and if they have a rehabilitation, but how hard strokes are on families and caregivers and partners. I just didn't know if you wanted to say a word about that. I mean, I think that there's like amazing things that we can do, but I also want to, I guess I'm asking you to also to feel the hope for those who have strokes and might have a few deficits, and by that I mean effects of that stroke, what life is like for everyone.
Well, I'll tell you, we see stroke patients in many different times. And I am so fortunate. I get to see them on the street by their house.
Yes.
I get to see them inside of the angio suite. I get to see them, in the hospital. And I get to see them when they recover afterwards, after rehabilitation. And one thing I always tell stroke survivors, number one, your mood, your affect, your will to improve is 100% correlated to how well you're going to do. So many times we will give patients some medications that help increase their mood, better their mood, that can also help motor recovery. Because I want to advocate for them. I want them to advocate for themselves. And the other thing I always tell them, all strokes improve. We can't predict the degree to which it improves. Some
or
people improve
towards
100%, some people 60, some people 70. But I know you're going to get better. I want you to believe that I know you will get better. I want you to know that you will get better. And the greatest recovery perhaps we see in the first 6 weeks to 3 months, but improvement continues for 1 whole year.
Yeah.
Where you are at 1 year is your new baseline. And I tell the family members one piece of advice when I go to the bedside, especially for patients where every 24 hours we have to just make it past the next 24 hours. It's overwhelming to think in 3 weeks what's going to happen, in 1 month what's going to happen. We have to take it one day at a time, and you have to take time for yourselves to recover. As a family member, you have to take care of yourself so you can take care of others.
I think that's very important. I say that all the time to my patients too. I know that you're going to get better. I think that's very powerful, and I think it's hard. I mean, right, we talked about, that it's very scary, right? I think for people to feel like their parts of my brain have died, right? And then all of a sudden I can't move my leg too. But you can feel better and you will improve, perhaps quite slowly, but there will be improvement.
Yes.
But that's really important to hear. I think that just sort of the mood, the well-being, and also just for caregivers, how they need to care for themselves.
And today, as I was showing the imaging of a patient to his wife, and the imaging looks like a lot of the brain is missing. And I say, we don't treat the imaging, we treat the patient. This looks very bad, but look how he looks.
That's right.
So recovery is miraculous. People can be motivated. The brain can rewire. We have to encourage patients.
And that's really amazing about the brain. So even if some of the brain cells die and don't regenerate, other parts of the brain can take over. That makes us, we're very
complex.
Despite everything, we're a very cool species. Or just, I guess all animals are this, but it's really neat. Yeah. What gives you kind of hope then as we move forward in your field?
people who believe in the cause.
Yeah.
You know, people such as yourself, people who believe in the cause, who believe that we can impact change.
Yes.
People who are forward thinking to look at innovation, not just for today. Like I said, what's going to happen in 10 years? What's going to happen in 20 years?
Mm-hmm.
We have to think for the future. We don't have to think and look under our feet. And we have to do that all with the drive and passion that we have for improved patient care. We went into this field because we had a mission, and we knew that we wanted to deliver better care to patients. And yes, we have hard days, and yes, we have hard jobs, and yes, sometimes the disease beats us and we can't help the patients, but we still go the next day, and we still go the next day for the hope that we can impact one person's life.
It's amazing. You literally are a living testament to your own hope. Do you mentor a lot of people?
I mentor a lot of people.
I
yes.
bet. You are so inspiring.
Thank
and your
you
patients
so
are
much.
so lucky to have you.
Thank you.
I mean, I feel like our whole organization, too, is so blessed that, again, for your innovations and your, forward thinking. I love that even with this incredible innovation that you're still just kind of thinking go, and move forward.
In fact, our mobile stroke unit, the 2 recent mobile stroke units, thanks to philanthropic funds that we got from the Brett Torino Foundation, the Karen Canarelli Foundation, we are so fortunate. We had the first, most advanced mobile scanner in the world. We were the first in the U.S. to have it and deploy it here. So we continue to push, boundaries and look further and further innovation.
And we're all the beneficiaries. I have seen the mobile stroke unit across the street from my house, and I'm like,
oh wow.
Dr. Nour.
For me, it's a celebrity sighting when I start video. Like, why do I video? I was just on that thing an hour ago.
It is kind of a celebrity sighting.
I get very excited.
I'm excited for you. This has been such an incredibly valuable conversation. I mean, everything that you do is just honestly so groundbreaking, but also so kind of human and everyday moving. And you certainly make something that seems, very terrifying and very overwhelming, not just understandable, but it actually feels very actionable. And I think that in itself is reassuring, and hopefully gives our listeners the agency, the autonomy to say, like, you are in control. This doesn't just have to happen to you.
Yes.
You're not to blame if something happens, but you are in control of mitigating, these risks. I want to remind our listeners about BEFAST. And also to teach it to 5 people that you care about, because clearly it saves lives. Anything else I forgot?
Keep the hope.
Yeah.
Keep the hope. Keep on the lookout. Keep the hope. Keep improving your own health. Keep being a positive beacon for others in your life. And that makes a whole lot of difference in recovery.
It does. And thank you for being a positive beacon for all of us. Thank you so much for joining us today. For our listeners, there's resources. There's going to be stroke education materials in the episode notes. I'm Dr. Eve Glazier. This is Medically Speaking. And until next time, stay curious and healthy. See you next time. Thank you so much, May.